So Darren Nolan from Newcastle in Australia is here. And so I will pin you guys up and we can, maybe Darren can start a bit of a discussion between Rita and Leah and himself. And then we'll, after a few minutes of that, go to some of the Q&A.
Sure. First of all, thank you for the invite to be part of this wonderful group of series of seminars. Yeah, I'm from Australia. I am a proud Aboriginal man, and my nation is the Wiradjuri Nation, which is in the western part of New South Wales. And so I'd just like to sneak in a quick acknowledgement of the people and the traditional custodians here across the footprint of the University of Newcastle and the University of New England, which covers many nations, and of course acknowledgement to the Wiradjuri people, and paying respects to our traditional and our elders past, present, and I also do pay acknowledgement to the building of community and the reconnecting with culture, law, and language across the communities across this country. So it's a time for reflection on what's happened through our colonisation, and also a time of growth and building that we can see where we have a significant input in the works that are happening today, which is great to see in the conversation that we've had here this morning with Rita. It's nice to see that while we are echoing a lot of the things that we teach within the universities here. I work within the College of Health, Medicine and Wellbeing at the University of Newcastle, and we have a wonderful program, which is a joint medical program that spans across the University of Newcastle and the University of New England, which is in fact where I'm sitting today. I'm in a town called Armidale at the University of New England, and we support our Aboriginal and Torres Strait Islander students that participate in that program across both universities, all the way from high school, or from where the dreams are sown, where the students want to be doctors. We take them along a pathway, and there's a couple of pathways they can come into the medicine program to become aspiring health practitioners, and work with them in not just the recruitment, but it's important to provide that support in the retention to get these students through to their graduation and on into being able to work back in communities and bring the best thing for Aboriginal communities, we believe, are Aboriginal doctors. And so if we can do that, and we've seen more than 120 Aboriginal doctors graduate from the University of Newcastle and New England, which we're very proud of. So it's great to see the information and the messages that we're teaching into these programs. I work in communication, and I was excited to hear some of the conversations about looking at with Rita taking the perspective that power out of the doctor patient relationship, and looking at health from the patient's perspective, and and that's what we work with within medicine, to teach the doctors, the students that are coming through, to look at that relationship, to think about the patient's perspective, to understand that you are in a cross-cultural relationship. Although both people are speaking English, that there is a strong difference, the major differences in not just the verbal or the syntax that's being used in those conversations, but observing the non-verbal communication, acknowledging the things, respect that there can be a major use of silence that is different for Aboriginal people that might be non-Aboriginal speakers. They'll use silence in a different way, and understanding that a silence and respecting that silence as one of those non-verbal communication indicators. So it was interesting, and I love to hear that these conversations are bigger and broader than what we have just here. So yeah, it's I could ramble on today. The information we've heard so far has been really, really good. There are a couple of questions that I saw that have come through the chat room, and we had Julie DeLeman. Julie, you had a question to Lee. I think we sort of have to move on because time's getting away from us. Julie, did you want to ask your question again?
Darren, why don't you read out what she's written there, and I think we can do it that way.
Okay, sure. Yep. Okay, I'll just have to. Okay, so Julie has asked, she is wondering, do you think it's possible to transfer or send one's health healing energy to a loved one, example a sibling who has cancer, to help them heal and to help treatments work? If so, what are some of the strategies or practices to enhance that process? And that was to Lee.
Oh, definitely. You know, one of the principles is that we're all connected. And I think most people view themselves as an individual, or that's essentially the program that we've received from Western knowledge holders, is that we're very individualistic. But when you're looking at it from an indigenous perspective, you're part of a collective, and you're not disengaged, you're always engaged. And so whatever you're doing, whatever you're thinking, and has an influence and an impact. So I think there is some actual literature where there was some extensive research done in a book called The Power of Eight. And I forget the name of the lady now, I'm sorry, but what she did is she would place an individual in the center of the circle and have 8 people sitting around and just thinking good thoughts about the health and well-being of the individual in the center. And people would actually spontaneously recover from chronic diseases and or cancers that they were. So it's possible. And I know my husband has been living with cancer for the last 7 years, and he has surpassed the timeline that he was given. And a lot of that has to do with the ceremony. And when we're in ceremony, that's what it's all about. It's about having others that are thinking about you and sending you love and for healing and to recover, to have strength. So it is possible. It doesn't matter where you are. We often do distance healing, you know, through our prayers and through our ceremonies.
Can I ask a quick follow-up on that, if you don't mind?
Mm-hmm.
You know, what you're saying, Leah, is consistent with lots of other traditional cultures. You know, even the Buddhist meditation, you know, that I've got some training in, there's many practices around, you know, wishing well for other people and helping them heal. And so I wonder, like, Rita, also from your perspective, you know, this is a very a different way of thinking than, you know, traditional deterministic Western medicine. And they often poo-poo it, you know, oh, what is this, you know, energy, whatever, you know, the ancestors. Like, how do we bring these really diverse perspectives, you know, together so that there's more acceptance? There's lots of things we don't know in Western medicine, and there's other ways of thinking about this. Like, do you have ideas around, you know, how we can best do that? Any of you?
Go ahead, Rita.
I'd say, for one thing, I position myself as a Western researcher. So I, like, part of our, within the medical school, our TRC process, when we looked at the call to action around greater access to indigenous healing approaches, we were really clear in recognizing that in medicine, we're not traditional healers. And so we don't pose to do that. But, you know, just this morning, a group of us through family medicine and led by Dr. Kirshu had a 2-hour forum on the patient medical home and its possibilities for indigenous primary health care in Alberta and what it would take to achieve that. And I think a big message that I heard through this discussion, the discussions we had this morning, was the reimagination, the need to reimagine healthcare is not a set of technical services that are provided, but a suite of care for human needs. And that it just so happens that there's often a physician there, but there should also be other people that are connected to providing care for human needs. And so I would, you know, as a person that's not traditional and not even indigenous, I would just say that we just need one of the instructions is we need to imagine healthcare differently and why we organize it. That's how, as a models of care scientist, I advocate for it. But at the same time, like, there is a question to me about, and I'll just quickly answer it. Like, there is a question about how do we measure patient outcomes in, like, how do we try to achieve a randomized control trial? And we actually looked at patient data charts of 179 patients, indigenous patients of of physicians that had taken the training that we provided. And we tried to compare it to patients of physicians who had not taken our training in similar communities. And the RCT, the randomized control trial, wasn't quite successful because all of the physicians in the comparative group, in the compare group, had left within a year of, and so we didn't even have the capacity to compare those that had received the impact of physicians that had received training to those that hadn't, because there's that much discontinuity in care in many communities by a provider. So there's certainly not anything close to a patient medical home. What we could observe, though, in the charts of patients whose physicians had received it and those who had not received the training, was that over the course of the year, we actually saw a reduced pharmacologic load in patients. So we saw that there was, and that's just one aspect of it, but there was like an increased rate of patients completing their labs because, and we theorize that it's because the nature of the clinical or the therapeutic relationship was actually renewed, and there was indications that there were actual meaningful conversations that were re-exploring what exactly are the therapies that a patient needs to be accessing. So we used kind of very Western indicators to explore possibilities for improved care and the restoration of trust. And then on the point of training more people, it's not just about training more providers, although that's very important. Call 19 of the TRC emphasizes the need to track health disparities and the closing of gaps, and that requires the training of more epidemiologists, indigenous epidemiologists that understand the types of indicators that we should be actually following. And I know Dr. Janet Smiley at the University of Toronto is trying to, I think her ambition is to train 100 indigenous epidemiologists in the next 10 years in Canada. I don't know where she's at with that, but all aspects, health research, health service, leadership, health systems leadership, all require more indigenous inclusion.
Thank you. That's great. And there was and I just wanted to add to the question about the energy. And I think the energy, we know that we're connected to everything, including the earth. And often it's when you go home, we get a drive. I know that I get an absolute drive to want to go home to my own country, which is out west. Take my shoes off and put my feet in the dirt, and you can feel the energy that comes through there. So the energy that is put out into the universe is energy that is being received, not just that connection from a one-to-one that we have people to people. There was also another question there. Working from my phone today, and I'm feeling a little bit technically challenged because I don't do technology well. I think, Rita, did you answer the second question there with the colonial legacy? I think we've covered that with cancer, with the effects of cancer care specifically.
I can respond a little bit to that. Like, I think
Sure.
In terms of the colonial legacy, in the work that we did here in Alberta, interviewing cancer patients, cancer survivors, that whole colonial legacy piece was very, very evident because it did impact their perception of the cancer care system itself, especially if they had experienced trauma. Because when they would go into receive treatment, whether it was surgery, whether it was chemotherapy, or even just meeting with an oncologist, if in any way that their trauma was triggered, it would impact a decision to make whether to return for further treatment or even to continue on with seeking out additional support and help. So we see that often over and over again, and which requires a lot more thoughtfulness, I think, on the part of the system itself, is how that can be mitigated or at least addressed in some way. I've talked to ladies, for example, who have had cervical cancer. Sometimes the care providers or even the technicians that are actually doing tests, things like x-rays and that, they're just not present. So when we talk about healthcare providers and or technicians, if my firm belief is if they go back to the original reason why they entered into the profession itself, and I think this is part of the problem, we see healthcare as a profession and not as a service. When this is the difference between indigenous healers and healthcare professionals. There's a very clear line. One is very much focused on individualism, profession, and economics. It's the economics that's driving it. Whereas on the other side, it's you have been selected or you have been deemed to be a person of service to a community or to a collective. And so you are actually governed by whatever the spirit or the guides or your spirit council that's there. That's what you're accountable to. You're not accountable to an economic system that tells you you're going to be paid this amount of money for X number of hours of service. And at 5 o'clock, you're done. Our work is never done. It's always there, because when you're out walking or you're in doing something, invariably they'll come to you, and you have to take the moment to send that little prayer or to do something. You know, I'm sure physicians experience that too, but they just don't talk about it. They don't talk about it.
Yeah, it brings up a great point. And one of the areas that we work with the students is looking at the patient's perspective of what that cancer is. A lot of the times the students are being taught and the medical practitioners have that this is the cancer and this is the way forward and this is the process we have to go through, and they start down that track without taking a moment to understand the patient's perspective. And first of all, there may be a lot of translation required in the patient's understanding of what cancer is. There are a lot of words that when translated from traditional languages to Western language, the translations or the meanings are not transferred. And then taking that patient's perspective, where once the patient has shared that there is a cancer, and their mind will then race off and start thinking about the things that are priority and important to them, like looking after family, who's going to pick the kids up, all of these things which are nowhere near the journey where the practitioner has gone on what the healing is. We had a conference with our fourth year students recently, and one of the students, we asked the question, what does medicine mean to you now, with reference to what it meant when you ticked the boxes, when you had the goal, when you wanted to come to university, where are you now? And I think one of the responses was really, really humbling. And the student said, he's realized now that medicine's not always making somebody well, but making them comfortable, giving them respect, and to give them that the respect that they need, and to give them help them in the way that it's going to be for them. And I thought that's a real mature approach to not just looking at medicine is to find that solution. So we've only got about a minute to go. So certainly I'd like to thank everybody for allowing me to be part of the this seminars today, and certainly to the speakers. I've absolutely enjoyed hearing the stuff that's been shared today. So thank you all for that.
All right, well, I guess it's time to wrap it up. I know we're just getting started on the conversation here, but luckily we get to continue it tomorrow. So tomorrow at 11 a.m. Alberta time, we're going to have our final session in the series, and we'll have a keynote lecture from Dr. Nadine Caron from UBC. And then we're going to have everybody back for a panel. So we'll have Rita and Leah, Angeline. Gail isn't able to make it, but we'll have the four of them in a moderated discussion with Arrow moderating. So you can save your questions. I think we're going to have a great session tomorrow, and really appreciate people attending today, and especially Darren joining us from Australia. And so hopefully, well, it's the middle of the night for you guys tomorrow. I won't hold you accountable if you don't make it, but we will be recording the sessions and eventually posting most of the content on our website. So thank you again for wonderful talks, and we will continue the conversation tomorrow.